happy to take questions now if,
Actually, I see all of you very energetically taking notes. So not only will Peter be happy to answer questions, Julie, myself, we're certainly, if you want to direct questions to Dr. Slavin or Dr. Pomeroy in terms of the teaching hospital or the medical school perspective, we'd all be happy to answer your questions. Yes?
The HHS and CMS have a partnership for patients, and I wondered if you could talk about whether you're looking to get some support from that program for what you're doing. Financial, money.
Yeah, we always could use extra infrastructure support for an initiative like this. It's not cheap, nor is it easy. That's still actually being developed in terms of the funding opportunities. But we actually see a really perfect alignment, because if you look at what the Partnership for Patients, at least their initial 2 goals, they're very aligned with the best practices for better care initiatives. So certainly AAMC has been a sign-on already for that initiative. We were one of the early supporters, and certainly we take advantage of any infrastructure support that we could use to refuel this. We actually believe this is not just a 2-year effort, that there'll be additional initiatives that we'll want to roll out once we launch these 3 clinical and the education and research initiatives. So. Other questions?
So
Yes.
who's measuring these checklists? Or who's developing these checklists, and are they supposed to go into implementation like this month, next month? Who's measuring it? Who's sending you guys your results?
So I can let Julie answer that. The UHC actually already has a collaborative ongoing with, for example, the use of the surgical checklist and central line infection rates. Julie, do you want to address that?
We do have collaboratives that are ongoing for each of the initiatives that we've talked about. Catheter-related bloodstream infections, surgical safety, and also reducing readmissions. And so we have some experience with developing the process measures and looking at the evidence and collecting that information. We are in the process of identifying the outcome measures. So we have a very large data repository at UHC, which we would be able to pull the outcomes measures out of for, I would say, 70 to 85% of the organizations that will be participating in this initiative. And then we're defining the specifications, so organizations who don't participate in that database, but who do participate in other large data repositories will be able to pull that data out. And our effort is going to begin very soon. That was one of your questions. Our effort's going to begin very soon. Our intention is to pilot with 10 organizations by August. So 10 selected organizations will start to send us data. And that's going to be just to smooth out the mechanisms to get the information. And then we'll roll it out more broadly in, I think, Q4 we're looking at.
Do you want to talk about the reports that we discussed going back to the institutions?
Yes.
So they can act on their data?
Yes. So we are in the development of reports that will include both process and outcome measures. These reports are going to go back to each organization that's participating on a quarterly basis. It will share with them their performance data. It'll give them the relative performance among the peer group that's participating. So they'll see who the best decile performer is, best quartile, the median. They'll be able to see where their performance fares relative to those peers. And they will also get trended information. So they'll be able to see their performance over time. And I think that's probably one of the most important things, is getting that data in their hands so that they can see, are the things they're doing really impacting the outcome of interest? Because if the things they're doing are not affecting that outcome, then the questions are, why, what else? And it sometimes, in fact, comes back to leadership roles, responsibilities, commitment, accountability mechanisms within the individual organizations. But the data will be provided on a quarterly basis, so they'll be able to see that performance trend.
So they're seeing the performance trend for those 10 organizations participating, or for all 130 or 200?
So they're going to see their individual performance trend.
Okay.
And then they will see their comparison relative to the group. So they will see, my metric, and I'll see over each quarter, what does my metric look like? Is that metric improving? And then, how is the peer group doing? Is the peer group improving? And how do I fare relative to
And then when do clinicians and students start to use these results in practice?
So
Yeah, so that is actually the educational research aspect of it. So the key is actually to get this information into the hands of students and residents. So we're developing actually a very elegant participatory reporting system that actually involves nurses, the faculty clinicians, undergraduate medical education students, so medical students, and the residents. And in these, the very brief questionnaire they complete on a quarterly basis, we actually ask them whether or not they have access to the data. Do they know their institution's central line infection rate? Do they know the infection rate within the unit in which they're working? And actually asking them issues related to were all the steps of the central line bundle actually followed? If somebody didn't follow the step, would they have felt confident enough to stop the process and to alert somebody that incorrect procedures were being used? So this is really, you dig into the perception and the environment that sometimes with the best process, if you don't have the right environment and you don't have the right culture so people can pull the cord and say things are not right, that's when mistakes happen. And that's when you have all the policies in place but you don't budge your central line infection rates. So, did that answer your question? Yes?
I'm Jason Shear, a future medical student, and I wanted to know how this is going to affect my curriculum.
How it will affect your curriculum? Claire Pomeroy can answer that.
Well, first of all, good choice, future medical students. We approve of that. We understand that if we're going to create the workforce of the future, the healthcare workforce of the future that our country needs, we need to have students learning in a culture of quality. And so what that means is that from day one, when you come to medical school, there will be in your curriculum, in the courses where you learn to take a history and physical, in your cardiology course, there will be discussion of quality, and there will be evidence-based presentation of the science of quality. You will also, in your curriculum, see and interact with your faculty who are doing implementation research, who are defining how quality is going to be achieved in the future. So academic health centers are in this very special place, which is that we not only create the workforce of the future, we develop the new ways of doing things through implementation science, and we drive clinical innovation in our hospitals and clinic. And so when you come, your curriculum will be talking about quality, you'll be learning about checklists. When you go out into the clinic, you will be getting that data about your performance, and you'll be observing your faculty and the hospital staff working in a way that values quality and is driven by evidence-based medicine. It actually is going to transform your experience. In the old days, we sometimes had this idea that you could kind of learn by doing. I'll give you one specific example. Right now, you don't put your first IV into a live patient. You come to a simulation lab, and you learn and you perfect that skill before you go out and interact with a live patient. And only when the faculty who are guiding your curriculum say that you're ready to do that, are you allowed to do that. That's a transformation. That's how we're going to teach quality. And welcome to medical school.
Thank you.